Hi, my name is Leland Peng, and I'm a medical student at the Duke University School of Medicine. My presentation is titled A Population Health Strategy for NAFLD using an e-consult platform and NLP. Non-alcoholic fatty liver disease can more readily be characterized as a spectrum and is the most common cause of chronic liver disease in the United States, affecting approximately 1 out of 3 adults. While most patients with NAFLD have simple steatosis, 25 to 30% have the progressive subtype non-alcoholic steatohepatitis, which increases the risk of fibrosis, progression to cirrhosis, and the development of hepatocellular carcinoma. NAFLD is typically asymptomatic and under-recognized, and often first diagnosed in the setting of significant disease decompensation. The development of new medications, however, allow treatment of the disease process earlier and increases the need for better diagnosis. A key component of NAFLD diagnosis is recognition of fatty infiltration on radiology reports. Due to the significant amount of abdominal imaging for other etiologies, however, information regarding NAFLD is often not relayed in a timely manner to specialists, delaying intervention. By focusing on radiology reports at a single institution, we propose that generative statistics can adequately identify non-alcoholic fatty liver disease. In our study, we develop and compare a TF-IDF NLP model to a text search-based model for NAFLD detection using NAFLD ICD-10 coding as a gold standard. Secondly, as ICD coding is highly specific but has low sensitivity for NAFLD, we perform clinical review of the results of our TF-IDF model at 2 thresholds to compare our model to ICD coding. Our model was developed at a quaternary academic medical center. After exclusion criteria, 59,623 patients were eligible for inclusion. A prospective cohort from January 2019 to June 2020 was also curated. Our results show that our TF-IDF model outperforms a text search-based model in both retrospective and prospective validation cohorts. AUC in our retrospective cohort was 0.8 versus 0.71, and AUPRC was 0.32 versus 0.24. Similar results were shown in the prospective cohort with AUC of 0.78 versus 0.69 and AUPRC of 0.29 versus 0.25. Secondly, we randomly selected 100 patients from the model results at 2 thresholds. At 50%, indicating a NAFLD population of 3%, and a threshold at 4.5%, indicating a NAFLD prevalence of 22%. At both thresholds, our model identified more NAFLD patients than ICD coding alone. Future work remains to implement this model into clinical practice. Analysis of workflow integration has been performed and is diagrammed here. Furthermore, as the model is developed using a flawed gold standard, we will assess whether the model can be used to curate a more accurate gold standard dataset in order to improve performance. Thank you for your time and attention.